Welcome to the 24th Annual Gene S. Marks Memorial Education Forum. We're thrilled to have you join us today. As in previous years, this event brings together leading healthcare professionals from around the world, offering premier educational sessions in the fields of sleep and respiratory care. Today, we're celebrating you, the essential healthcare heroes in our communities, with a dynamic lineup featuring 10 speakers from top universities, health systems, and supporting organizations. Here's a quick overview of today's program. This morning, we'll kick off with 4 sessions, including a keynote presentation. After a 30-minute break, we'll split into concurrent sessions, one focusing on sleep and the other on respiratory, running through the rest of the day. Each session will be followed by a 5-minute break, allowing you a brief pause before diving into the next topic. Throughout each session, you can submit your questions via the Engage tab above the presentation screen, and our speakers will address them as time permits. The respiratory track sessions are approved for continuing education credits by the AARC, with additional approvals from the BRPT for morning and sleep sessions. During each session, you'll be prompted to evaluate the presentation and speaker. If you miss this pop-up, you can always complete the evaluation later by clicking the Check-in Survey button above the session name. In addition, your certificate of completion will be emailed to the address you registered with tomorrow, Friday, November 22nd. We'd like to extend a special thank you to our speakers, sponsors, and DME partners. Sponsors, your support is invaluable, and we couldn't offer this event without you. By working together and sharing valuable knowledge, we strengthen our ability to provide exceptional care to the millions of Americans living with sleep and respiratory conditions. DME partners, it's inspiring to see us unite for the benefit of our patients and communities. By working together and sharing valuable knowledge, we strengthen our ability to provide exceptional care to the millions of Americans living with sleep and respiratory conditions. Lastly, before each session, you'll hear from some of our MSC team members sharing more about how we can support you and your patients. For further details, visit medicalserviceco.com. Thank you, and let's get started. Our first speaker of today's forum is Dr. Andre Aguillon, who will be presenting on using AVAPS in the Respironics V60 ventilator. Dr. Aguillon graduated from medical school at the University of Toledo and continued on to complete 2 fellowships, one in internal medicine and one in sleep medicine. He began his career as medical director for the Regional Center for Sleep Medicine in Toledo, Ohio. Currently, Dr. Aguillon is serving as the program director for the Sleep Medicine Fellowship Program and assistant professor of the Division of Pulmonary and Critical Care and Sleep Medicine at the University of Toledo College of Medicine. He is also the founding medical director of the University of Toledo Medical Center Sleep Disorders Center. Throughout his career, Dr. Aguillon's passion for education has been at the forefront as he has contributed numerous service-related developments and innovations in sleep and critical care, and has taught multiple courses and advised several residents and fellows. Thank you, Dr. Aguillon, for your participation in this year's forum. If you have any questions for Dr. Aguillon, please submit them using the Engage tab above the presentation screen. Please remember to complete the survey evaluation after the lecture to receive credit for attending. We hope you enjoy today's forum.
Hello, everybody. I'm Dr. Andre Aguillon. I'm a sleep medicine physician at the University of Toledo in Toledo, Ohio. And I have the distinct pleasure in talking to kind folks about using AVAPS in the respiratory V60 ventilator. Now, volumetric pressure support is an advanced form of non-invasive ventilation, and which is a very powerful, I would say, and versatile mode to use in both a sleep setting and in an acute care setting. But volumetric pressure support is more known, I would say, in the sleep tech world compared to the respiratory tech world. And the V60 ventilator manufactured by Philips Respironics is a non-invasive ventilator that's used in the hospital. So, of course, this will be more familiar in the respiratory therapy world compared to the sleep tech world. So my attempt is to blend the 2 worlds together. And and it's very useful in patients who have uh, particular pulmonary disorders. Not too many pulmonologists, pulmonary physicians use or are aware of volume assured pressure support unless they have a sleep background. Now, as for me, just as a disclaimer, I'm not a board certified pulmonary physician. I just do sleep medicine full time, but I like to say that I can speak the language of a pulmonologist, so we can uh, um, uh, collaborate. All right, so let's just move on here. All right, so I do not have any conflicts of interest. And in this discussion, we'll talk about the principles of non-invasive ventilation, and then we'll describe the different modes of NIV, including volume assured pressure support. And then we'll apply NIV concepts in using the AVAPS mode in the Philips Respironics V60 ventilator in an acute care setting and in a sleep setting. So in the sleep world, there are different types of sleep-related breathing disorders that we see and that we address and that we treat. So we have obstructive sleep apnea, where we have a continued effort to breathe, but against an obstructed upper airway. They have central sleep apnea, where we have problems with the effort to breathe. And then sleep-related hypoventilation or hypoxemia, where you have problems with gas exchange at the level of the alveoli. Now, you can divide the different causes of hypoventilation into hypoventilation due to lower areas obstruction like COPD, or due to a pulmonary parenchymal pathology like interstitial lung disease, or hypoventilation due to neuromuscular and chest wall disorder like ALS, for example, or kyphoscoliosis. If you want to think big picture, these are your obstructive lung disease, these are your interthoracic or interparenchymal restrictive lung disease, and these are your extrathoracic or extraparenchymal restrictive lung disease. Now, in regards to positive airway pressure therapy, there are different types of PAP device or PAP modes that we use to treat the various types of sleep-related breathing disorders. So you have CPAP, bilevel, auto PAP in the form of auto CPAP or auto bilevel, adaptive servo ventilation, and then volume assured pressure support. Now, when we treat hypoventilation, which is the focus of the population of patients that we're going to treat, we treat hypoventilation through either non-invasive ventilation, for example, in the form of bilevel or bilevel ST or volume assured pressure support. In extreme cases, you can treat with tracheostomy, or you can just use oxygen therapy for those who have sleep-related hypoxemia. So let's dive deeper into non-invasive ventilation. So here we have a schematic diagram of how NIV works and the components of NIV. So you have the machine and device with the flow generator, and then you have the mask, which is the interface between the device and the patient. And then you have the upper airway component and the interthoracic component. Okay, and NIV will address both the upper airway component and the interthoracic compartment, which is dependent on pulmonary system compliance, which includes the lung and the chest wall. And then you have an effective pressure support that will only be delivered when the upper airway resistance is overcome. So this is different from CPAP, continuous positive airway pressure, which only addresses the upper airway component. So it will not address the interthoracic compartment. When a patient is intubated, you know that the ET tube has a direct access to the interthoracic compartment. And then for tracheostomy, the tracheostomy works by bypassing the upper airway compartment, and that has direct access to the interthoracic compartment that way here. All right. Here we have a pressure time curve for the describing the different components of non-invasive ventilation. So you have pressure as a y-axis, then time on the x-axis. So you have the IPAP, or the inspiratory pressure, positive airway pressure here, and then you have EPAP, the expiratory positive airway pressure over here. And then your IPAP, EPAP differential or your delta, that's called pressure support. And this will be equivalent to, or this is applicable when you're working with mechanical ventilation. And for vents, EPAP will be equivalent to your PEEP. Okay, and then when we start on EPAP, then you have the trigger, and the trigger is that point at which your breath begins, or that point you go from EPAP to IPAP, or that point that you go from expiration to inspiration. And then you have your rise, which is how fast that you go from EPAP to IPAP. Then you have your I time or inspiratory time, time on inspiration. Then here you have your cycle, which is the point at which your breath ends, or that point that you go from IPAP to EPAP, or that point that you go from inspiration to exhalation. Okay. And then you have your fall, and then you have the respiratory rate. And then the area under the curve is your tidal volume. And that's really the name of the game when we're trying to treat these patients in acute care setting with pulmonary disorders. And our goals of NIV is to provide adequate ventilation, oxygenation, to provide adequate tidal volume. Again, that's really the name of the game here. And we can customize NIV settings to the patient's unique physiology of respiratory disorder or failure. So let's take, for example, a patient with restrictive lung disease. All right. So let's, for example, a patient with ALS or neuromuscular disease. All right. So what is the main problem here in patients with restrictive lung disease? Is the problem more on inspiration or exhalation? Now, the answer is inhalation. Okay, because in these patients with neuromuscular disease, their muscles of respiration, okay, like the diaphragm, the intercostals, the accessory muscles, sternocleidomastoid, they're too weak, all right, to bring in that tidal volume that they need. Okay, so when we treat these patients, we set the NIV such that they're spending more on inspiration than exhalation. And the way we achieve that is that we have a longer rise time, a longer time in inspiration, okay, as well as a low respiratory rate. We want their cycle, we want the breaths to cycle slower, meaning that you do not want them to go from inhalation to exhalation very easily. You want to have them stay in inhalation as much as possible. And for patients with neuromuscular disease, you want the machine to trigger the breaths quicker, again, because their muscles are too weak to trigger their own breaths. All right. So the type of breathing pattern that you want is more like hold, 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 and by having a longer rise time, as you can see, you're going to try to recruit as much alveoli as you can. On the other hand, let's take a care of a patient with COPD. Okay, now is their problem more on inhalation or exhalation? And the problem is more in exhalation. Now, for these patients, their muscles of breathing are not compromised. They could trigger their own breaths, but the problem is that they have so much air trapping that they cannot get rid of that trapped air. So the way we customize our NIV for these patients is that we set it such that they're spending less time in inhalation and more time in exhalation. And the way we accomplish that is that we have a shorter rise time, a shorter time of inspiration, and we'll want to cycle the breaths quicker. So the type of breathing pattern will be more like, okay, as opposed to for a restrictive lung disease patient. Okay. Now, when we treat patients with hypoventilation syndromes, okay, the conventional traditional method is bilevel with an ST with or without supplemental oxygen. And in this case, you have the IPAP is fixed, the EPAP is fixed, and therefore the pressure support is fixed. And typically, what we think that, oh, by increasing the pressure support, okay, or your IPAP-EPAP differential, you're therefore increasing the tidal volume. But this can actually be limiting in conventional bilevel because it's ceiling limited, meaning that your IPAP will get maxed out. It's also floor limited, that your EPAP can only get so high that your pressure support is maxed out. And then you also have tolerance issues where your IPAP or your delta, your pressure support, could be increased, okay, but you have intolerance that limits that expansion. So to address this, a new method of NIV was developed called volume assured pressure support. Respironics, they called their mode AVAPS, meaning average volume assured pressure support. The average meaning average tidal volume, which is part of the algorithm. And then, I guess, not to be outdone, ResMed, they call their device IVAPS, where the I stands for intelligent volume assured pressure support. And the intelligent refers to how their backup rate and their patient device synchrony works. Right now, let's just kind of go deeper into the different types of NIV modes here. Okay, so you have bilevel or bilevel S, which means spontaneous here. Okay, and in bilevel S, okay, the patient can breathe spontaneously, and the breath rate and the time inspiration or I time is determined by the patient. Okay, so they can breathe however fast or slow they want, and they could determine how much time and inspiration they want to spend at. And here, keep note that the pressure support is fixed, meaning IPAP is fixed, EPAP is fixed, and therefore pressure support is fixed. All right. Then you have bilevel timed, okay, where the patient can breathe spontaneously, but their breath rate and their time and inspiration are fixed regardless of patient effort. Okay. And that fixed breath rate and the fixed inspiration time is determined by the clinician. Okay. And just like bilevel spontaneous, bilevel timed, the pressure support is fixed, meaning your IPAP is fixed, your EPAP is fixed, and therefore your delta or your pressure support is fixed. Now, when we move to bilevel ST or spontaneous timed, you have two types of breaths. Okay, you have a spontaneous breath, okay, where the patient can initiate their own breath, and then you have a time breath. So, in this case, if you you set a breathing rate, okay, on the device, and if the patient's respiratory rate falls below your target breath rate, okay, then the device will kick in and deliver that extra breath. All right. So, for example, if you set your breathing rate at 15 and the patient's respiratory rate will drop to 10, then the machine will kick in, give you the extra breath, so you can meet that target respiratory rate. Okay. So again, you have a spontaneous breath and a time breath. Now, the difference between the spontaneous breath and the time breath is that in the spontaneous breath, the I time or the time inspiration is determined by the patient, okay, as opposed to the time breath where the I time is fixed, and that is determined by the clinician. Okay, and then you see here that the tidal volume between the spontaneous breath and time breath can be inconsistent. All right, and just like the previous modes, the pressure support is fixed. Again, where IPAP is fixed, EPAP is fixed, and therefore your pressure support is fixed. Now let's go talk about the difference between ST mode and pressure control mode. Okay, because they're very similar with slight differences. So, in both the ST mode and your PC mode, okay, you have the same two types of breaths. So you have the spontaneous breath, where the patient can trigger their own breath spontaneously, and then you have the time breath, um, where the that breath is determined by the device. Should the patient's respiratory rate fall below your target rate on the device. Now, the difference between ST and your pressure control mode is that on the spontaneous breath, okay, that the patient can cycle out of IPAP by themselves, okay, um, as opposed to on a PC mode, this on the spontaneous breath, the patient cannot cycle out of IPAP. So let's say in an ST mode, if I set my I time um, at, let's say, 1 second, okay, and let's say as a patient, I want to stop inhalation at zero point 0.5 seconds, okay. Now in ST mode, it will allow me, okay. Now on a pressure control mode, as a patient, if I'm breathing spontaneously, if the I time is set at 1 second, and let's say I want to end my breath at 0.5 second, the machine will not allow me. It will tell me, no, I am going to give you that full 1 second, whether you like it or not, on your spontaneous breath. Okay. And so you can see here is that just a reiteration of what I said, that the I time is only applied to time breaths on ST mode, and then the I time is guaranteed in both the spontaneous or patient triggered breaths and the time breaths or the device triggered breaths. And then you could see that the tidal volume is different. You could see the tidal volume is uneven between the spontaneous breaths and the time breaths, as opposed to here, you can see the tidal volume is evened out on a breath by breath basis. Now, just like in all previous modes here, your pressure support is fixed. Again, where you have your IPAP is fixed, your EPAP is fixed, and then your delta, your pressure support is fixed. Now, when we move to volume assured pressure support, all right, here in you have the pressure support is now variable, okay, such that you can increase your pressure support. I'm sorry. So what happens here is that you set a target tidal volume, okay, and the pressure support will be variable. It will go up and down to reach that target tidal volume that you want for the patient. Okay, so that's these are just concepts. So conceptually, that's how each of these NIV modes are different, and we'll delve into volume assured pressure support in more detail in just a few slides here. All right, so when do we use these different NIV modes here? So for bilevel S, it can be applicable to any clinical scenario in which the proper minute ventilation can be sustained based on the patient's natural respiration rate. Time rarely used. ST mode, you can use it in the setting of COPD. That this uneven tidal volume may be beneficial by assisting ventilation without facilitating air trapping or hyperinflation that may limit tolerance or NIV. Pressure control mode may be advantageous in the setting of a neuromuscular disease when diaphragmatic fatigue will drive an otherwise short I time. And volume assured pressure support, not inferior to bilevel ST in management of OHS, COPD, or neuromuscular disease. But I would say in an acute care setting, this is a superior mode, and I'm going to do my best to train you guys on how to use this in an inpatient setting. So what exactly is volume assured pressure support? So it's also known as a volume targeted bilevel, and it's a pressure volume hybrid mode of pressure support volume controlled ventilation, and it delivers a more consistent tidal volume with the comfort of pressure support ventilation. And the pressure support or assistance delivered during the inspiratory phase aims to ensure a certain tidal volume that is calculated as a function of predicted body weight. And the device assesses the preset tidal volume or minute ventilation during a variable time window of 1 to 5 minutes here. Okay. And because AVAPS or IVAPS devices adjust pressure support based on the patient's respiratory cycle, breath by breath, they adapt to changes in severity of disease or disease progression, and therefore ideal for sleep hypoventilation or respiratory insufficiency. And by tailoring the settings to the individual's respiratory effort rather than the usual default parameters is associated with better nighttime gas exchange percentage of REM sleep and sleep quality. So the way it works in different hypoventilation scenarios is that for COPD, volume assured pressure support will compensate for changes in airway resistance. For patients with interstitial lung disease, it will provide adequate alveolar gas exchange and low lung volumes. And neuromuscular disease, it will maintain stable ventilation when respiratory effort fluctuates, especially during sleep. And for chest wall disorders, it will compensate for changes in respiratory mechanics, such as during nocturnal positional changes. And then for the difference between the AVAPS and your Respironics AVAPS and your Resmed IVAPS algorithms. So AVAPS will target average exhaled tidal volume, and it will augment IPAP to achieve a targeted exhaled tidal volume, as opposed to IVAPS, which targets alveolar ventilation, and it'll augment pressure support to achieve a targeted alveolar ventilation. And both target tidal volume and AVAPS and target alveolar ventilation and IVAPS are determined by ideal body weight here. Okay. In terms of the different settings in the various NIV modes, so if you start with bilevel spontaneous, you have the IPAP, EPAP, rise time, I time, and trigger and cycle sensitivity. Now, when you transition from bilevel S to bilevel ST, with bilevel ST, it's pretty much the same, except now you're adding a backup rate. And then when you're transitioning from bilevel ST to volume assured pressure support, the difference here is that, well, you still have the backup rate, but now your IPAP or your pressure support is variable, where you have a min-max IPAP or min-max pressure support. And then now you're adding a target tidal volume or target alveolar ventilation, depending if you're using IVAPS or AVAPS, such that that you have a variable pressure support to reach your targeted tidal volume. So I guess it kind of like in big picture. So in standard bilevel ST, the problem is that you can increase your pressure support as high as you want to, but you're not going to actually guarantee or assure them that they'll get the tidal volume that they need. But volume assured pressure support will address that. It will vary pressure support to a target tidal volume or target alveolar ventilation. Okay. On the sleep lab side, there is a titration protocol on AVAPS. I'm not going to go over the slide in detail because it is out of scope for this talk, but it's in my opinion it's a bit confusing. So now let's go to the really meat and potatoes of our talk, is how to use this in acute care setting. But before that, I just want to kind of let you guys be aware of the different types of home devices that contain IVAPS and AVAPS. So there are basically two types. You have the respiratory assist devices, and then you have the home ventilators. Now for sleep, we prescribe either the ResMed AirCurve STA or the Respironics Dream Station when we want to use volume assured pressure support for people with sleep-related hypoventilation. But if you want to discharge a patient on these devices, it's going to be challenging. And to do that, Medicare has these various measures or guidelines or parameters on through spirometry, pulse ox, nocturnal pulse ox, or ABGs to qualify them to be discharged on these types of device. I'm not going to go over in detail. Maybe if we have time in the Q&A, we can go over that in more detail. Now, there are these home ventilators that have the volume assured pressure support mode, and it also is compatible with patients who have a tracheostomy, so it does have that invasive interface. Now, to discharge patients on either the Astro or the Trilogy home ventilators, you need to have documentation on the chart that they have a neuromuscular disease, a thoracic restrictive disease, or COPD. I'm sorry, chronic respiratory failure consequent to COPD. All right. Now, on an inpatient setting, okay, you have the V60 ventilator developed by Philips Respironics, which has that AVAPS mode, and then you can use this on your patients on the floors. All right, and you can use in an acute care or inpatient setting. You can use this when the patient has acute respiratory distress and pending failure, like COPD exacerbation, OHS, myasthenia crisis, or any neuromuscular disease, spinal cord injury, or CHF exacerbation. You'll see that their tidal volume requirements change, okay, as you're diuresing the patient. You can also use this when you're transitioning from extubation to NIV, or when you're transitioning from IC to step down, or even in post-surgery like cardiothoracic cases. All right. Now, there's very, to my knowledge, there's very few studies on the use of AVAPS in these scenarios. But I would say in a clinical setting, this is something worth considering. Should you think that standard bilevel ST is not working? Now, when you're using the V60 ventilator, keep in mind is that you can't download data from the ventilator like you would do on a CPAP device. So it's impossible to know what pressure supports have been, and there's no integrated humidity. Now here you see on the display, okay, you have three different types of displays. So on the bottom one is the settings that the operator puts in. On the top panel, okay, is the patient data. So these are the numbers that the patient is producing, and then you have the waveforms, which we'll talk about. All right. So here are the controls, okay, and so you can set your tidal volume, your EPAP, your min P, which would be equivalent to your min IPAP, max P or your max IPAP, your backup rate, your I time, and you can also set your rise. And then there's options set, trigger, and cycle. All right, so let's look at first the display here. Okay, now here you want to look at leak. All right, just like when you're looking at CPAP device, you want to look for leaks. So the acceptable leak, according to the folks at Philips Respironics, is that you want it to be below 60 liters per minute. And even with a perfect mask, you should still have it at 10 to 25 liter per minute leak here. Next, you want to set your target tidal volume. This is probably the most important setting here. Now, what number should you choose as your target tidal volume? Well, it kind of depends on the patient. So for obstructive lung disease, you can use 6 to 8 mils per kilo multiplied by ideal body weight. For restrictive lung disease, you can use 8 to 10 milliliters per kilo multiplied by ideal body weight. Most published studies use a goal of 8 mils per kilo. In those with a chest wall restriction, that they may not be able to tolerate large breaths, you may start at 6 mils per kilo. And for patients with obesity, hypoventilation syndrome, or spinal cord injury, a large breaths may be required, maybe up to 10 mils per kilo. Now, in the sleep lab, we titrate target tidal volume or target alveolar ventilation to their SATs. Okay, and in most protocols is SpO2 over 90. Okay, so you put them on the setting, and you can observe how their SATs react, and then you can go up or down on the tidal volume depending on what your SATs. Now in the Resonant IVAPS, you can titrate your alveolar ventilation, your target alveolar ventilation by PCO2. Okay, now there's nothing on AVAPS that specifies this, but you can use this as reference if you want to adjust target tidal volume to your PCO2, like through a blood gas, for example here. In terms of setting your EPAP, EPAP would be determined as a setting to get the best mean airway pressure to support alveolar recruitment and airway splitting to relieve the patient's dyspnea. And you have to adjust to a setting where you're not too high to restrict exhalation and yet supporting the patient's work of breathing. Now, keep in mind that there's no auto EPAP function, so you're in a slight disadvantage there. So for your starting EPAP, you can set EPAP of 5 for either an obstructive or restrictive lung disease. For an OHS patient, especially because they have a thick, large neck circumference, a higher EPAP like 8 would be preferable to start them on. Okay. Now, what do you set your minimum IPAP to be? Okay. Now, according to their manual, you can set the min EPAP to EPAP plus target tidal volume divided by 60, or to make it easier, you can just say EPAP plus 8. For the maximum IPAP, you can set it at 25. Now, actually, technically, you can set it as high as 40 if you want to, but the reason why 25 is set as a maximum setting is because that's actually the critical opening pressure of your lower esophageal sphincter. So higher IPAP settings may lead to aerophagia and gastric distension. Now, in terms of the backup rate, now for a stable patient, you can set your backup rate at 8 to 10 breaths per minute or 2 below the patient rate. But of course, in acute care setting, they're not stable. So you want to set a higher rate for pending respiratory failure and pending intubation. Now, let's say you want to wean the patient off NIV into room air. How do you do it? So the way you do it is that you lower the backup rate, and as you're watching the patient, the spontaneous patient-triggered breath. So if you see that as you go down on the backup rate, and if you see that the patient's triggered spontaneous breath is close to 100% on the screen, that's when you can say, okay, the patient's breathing spontaneously on their own pretty much the majority of the time. I think this patient's ready to get off of NIV and just put them on room air. Okay. For eye time, for adults, you can use 1 to 1.25 seconds. For peds, a little bit lower. But keep in mind that as you go up on the backup rate, you have to decrease your eye time for patient-device synchrony. And then for rise time, on the ventilator, they have settings 1, 2, 3, 5, 6. Normal is 3. A 1 would be a faster rise time, and then a 6 would be a slower rise time. In terms of trigger and cycle sensitivities, the way you set that is that on the menu you have to press the it's on the menu tab, and then you press the auto track button, and then from there you can manually adjust the trigger and cycle. Now, this feature is not established in all V60 ventilators because on some that do not have this, you need to download it as a patch. Okay. So for trigger sensitivity settings, for an AVAPS, if you want to set from least to most sensitive, it's set to very low, low, medium, high, very high. On the Respironics, a little bit backwards, so it's normal, and then +1 all the way to +7 here, from least to most sensitive. And then for cycle, for the ResMed IVAPS, from least sensitive to most sensitive, you can set to very low, low, medium, high, very high. But on the Respironics AVAPS, they're a little bit backwards, so it's like -2, -1 normal, then +1, +2, all the way to +6 from least sensitive to most sensitive. So let's just put all of this together. So if you're taking care of a restrictive lung disease, okay, again, you want to set it such that you're spending more time on inhalation, less time on exhalation. So the way you do it is having a slower rise time, increase eye time, slower cycling, so this will bring your cycle sensitivity towards the -2 and a lower backup rate. For an obstructive lung disease like a COPD, now again, you want to set it such that you're spending more time in exhalation, less time in inhalation, and you're doing this by a faster rise time, shorter I time, and a quicker cycling. So this would be the cycle sensitivity towards a +6. Next, we have the IE ratio, which is the ratio of time in inspiration versus time in exhalation. And a normal IE ratio would be like 1 to 2. For a COPD, you want the IE ratio to be maybe like 1 to 3, for example. On a restrictive lung disease, you want the IE ratio to be towards like 1 to 1 or maybe 1.5 to 1. But the V60 ventilator does not have that IE ratio. So instead, they have this TI T total ratio here, where the TI is equivalent to your time in inspiration, and your T total is your time in inspiration plus exhalation. So if you want an IE ratio of 1 to 1, for example, that'll be equivalent to your TI T total of 50%. And if you want your IE ratio to be 1 to 2, you want your they'll be equivalent to having your TIT total of 33%. And then if you want your IE ratio of 1 to 3, okay, that will be equivalent to your TIT total of 25%. Okay, so let's go with a scenario here. Okay, so this is a patient that one of our pulmonary critical care fellows um, showed to me here. So for this patient, the clinician set the target tidal volume to 400, the EPAP at 5, the min IPAP of 10, the maximum IPAP of 20, the backup rate at 15, the I time to 1.35 seconds. Rise time is 5, so that will be a slower rise time, 40% FiO2. And we don't know what the triggering cycle was set at, but I think that we'll just assume that was set at auto track. So when you look at the when you're looking at the display, the very first thing that you look at is you want to look at the leak. And remember, you want the leak to be less than 60 liters per minute here. And the most important number is the tidal volume here. Okay, and you see that the set target tidal volume is 400, and the patient's actually getting 450 milliliters. So the patient is meeting above target here. All right. Next, you want to look at your peak pressures here, and with respect to your IPAP pressures and your tidal volume pressures. I'm sorry, your tidal volume settings here. So here we have the IPAP going from between 10 and 20, and the peak pressure is actually getting 12 here. Okay, and you see the target tidal volume is 400, and then the patient is actually getting 450. So the way you interpret this is that the patient, or I'm sorry, the with the range between 10 and 20, the patient's getting peak pressures of 12 to achieve a target tidal volume of 400, and the patient's actually getting 450 milliliters. All right. Next, you look at the backup rate, and then you have the backup rate set at 15, and the patient respiratory rate is actually 17. Okay, so that you can say the patient's breathing, above the vent, so to speak here. Next thing, you look at the triggered breath. So you see here that the patient is spontaneously triggering their own breath 73% of the time. The rest of the time, the patient is dependent on the machine. Next, you see the TIT total, which is 35%, and that's equivalent to an IE ratio of 1 to 1.85, so close to 1 to 2, which can be acceptable if that's what you're, depending on what you're treating the patient for. Now, if you want to manipulate your TIT total or the IE ratio, you can either adjust your I time, your rise time, or your trigger and cycle. Okay. next we see the minute ventilation here. Okay, now you have to look at the minute ventilation with respect to the respiratory rate, the tidal volume, and the peak pressure. So the minute ventilation is determined by the metabolic state of the patient and his or her inherent dead space. And because patients will adjust their minute ventilation to meet their ventilation demands, this parameter is viewed more of an indicator of severity of disease more than the appropriateness of the setting. So let's say this minute ventilation is pretty high, and you see that maybe they're pulling in high peak pressures, and let's say they're high on respiratory rate, or maybe their respiratory rate is too low. This may suggest that they're having increased work of breathing despite their settings we put in. That's maybe when you should think about intubating the patient here. Okay. And then here we have the waveforms. You have pressure, flow, and then you have volume. And then you see the teal is more of the inspiration, and the midnight blue is on exhalation here. So the way you want to interpret is that for like auto peeping, just like in mechanical vents, you want to make sure you look at the end expiration and the flow graph, and you want to make sure it goes to that 0 point. That you don't want to have this gap here, which is consistent with auto peeping. And then you can also look at your cycle sensitivity and your eye time graphics here. So you see that for a less sensitive psychosensitivity, you see that they're spending more time on inhalation compared to exhalation. If you look at the normal, a little bit hard to see here. And on the psychosensitivity side, if it's more sensitive, you can see that they're spending less time on inhalation compared to exhalation here. All right. I'm not sure how we're doing on time here. Because a lot of this we're getting into like the trouble. Okay, 3 minutes. All right. So we'll see how much we can go over here. So just looking at the waveform here. Here you have a scenario of your trigger sensitivity, where you have clear evidence of missed triggers as the patient effort is seen graphically and can be observing in the chest wall. So you see that it's just the patient is trying, but the machine is not giving. So the way you fix that is you want to increase the trigger sensitivity and then reevaluate here. I'll skip this here, and then I'll go to cyclical insensitivity. So here you could see that at the end of inspiration, you see that little peak here, okay? And, this is where the patient is trying to exhale, but they're exhaling against some resistance here, okay? So you see that, again, that little spike here. So the way you treat this is that you want to increase the psychosensitivity and then reevaluate here. Here is where the eye time is, the psychosensitivity is too sensitive, where you see that as soon as the patient inhales, he goes in exhalation right away. So the eye time is too short. So the way you want to address that is decrease your psychosensitivity. All right, I'll skip these troubleshooting issues here. Okay. Now let's say here that you set your max IPAP to 20, but let's say your peak pressure is like 18, 19, or 20. That means that the patient requires more IPAP pressures. So you want to consider increasing your max IPAP. And let's say in a scenario here, let's say that you set your target tidal volume of 400, but the patient's only getting 300. So to address that, you may want to consider increasing your minimum IPAP here. Okay. And let me just go through one more here. Let's see here. Okay, yeah. So just one more here. How do I know if the patient requires higher IPAP pressures than the max pressure setting of 25 to achieve target tidal volume? There'll be an indication be shown on the V60 ventilator. So I apologize. I kind of rushed through that. but hopefully you get the concepts. Now, of course, the V60 ventilator is going to be discontinued by Philips Respironics, I think around 2029, and as well as a support. But volume assured pressure support still exists in some form or another, like the Resmed IVAPS, for example. Um, but I hope you got the idea of just concepts of how NIV works and how volume assured pressure support works. And hopefully I would you'd be more comfortable on using on using this mode. And in our institution, we've been training our pulmonary fellows as well as sleep fellows on how to use AVAPS in inpatient setting. And again, this is a very versatile, very slick mode to use on patients that who are in trouble, and you want to try to avoid intubation as much as much as possible. All right. Um, so thanks for your attention. Thanks for your indulgence, and we'll see you at the QA session.
Good morning, everybody. My name is Leo Nizzi, Regional Manager of Sales and Support for Medical Service Company. I couldn't be more excited to start off our first Q&A for the 24th Memorial Gene S. Marks Memorial Education Forum. Thank you, Dr. Aguillon. What a great way to start off the seminar today. I know non-invasive ventilator, AVAPS, complex respiratory is a very hot topic in the market right now. So what a great way to start us off. I know we had a lot of engagement from our viewers today. So if you're ready, I'm going to jump right into the Q&A.
Yeah, let's go ahead. Hopefully you guys
Perfect.
can see me and hear me.
Yes, you are good. Thank you so much. So first question we had coming in from the crowd was with the continuing issues with V60 machines, to highlight some of the recalls and such that happened, how much longer do you think hospitals will continue to use these devices?
Yeah, so my understanding is that I think they'll start they'll be discontinued in 2029. So you have I guess five more years to learn about this device and kind of get used to it. But I'm sure that as I said at the end, that volume assured pressure support. I mean, it still exists in other forms like ResMed. They have their IVAPS. I'm not sure if ResMed is going to develop their own form of the V60, or if there's other companies who are going to develop their own volume assured pressure support. But I would assume that the algorithms will be similar.
Wonderful. From your experience out in the hospital, right, just to elaborate on it for some of our clinicians that are watching out there that work in these settings, what are some recommendations you might make for devices they should keep their eyes out for that are having the best successes with some of these patients, the best clinical results with some of these patients in those types of settings? Anything that you want to share with the group, right? There might be some people out there that are helping make these decisions about the next devices. So anything you want to share on that front?
Well, I can share stories what fellows have told me in the past. I mean, they tell me stories where uh, when when a patient is in respiratory distress in the hospital, and uh, they're just not finding any success with bilevel or bilevel ST. They switch them over to the AVAPS using the V60 ventilator, and they were able to prevent the patient from being intubated. So I mean, in my opinion, if you're comfortable with using AVAPS, I would just I would just put them on AVAPS from the start. I wouldn't even mess around with just standard bilevel or even bilevel ST, because as I said in my talk, you can only go so much on your IPAP and your EPAP and your Delta or your pressure support, but you're not going to necessarily guarantee or assure them they need the tidal volume that they need, and AVAPS accomplishes that. So I would just suggest just put them AVAPS on from the get go.
Wonderful. Thanks for elaborating on that. I know we had a few questions come in specifically to the concept issue, however you would like to phrase it, regarding air trapping in non-invasive ventilators. So just to give you the platform to discuss a little bit in detail, can you address air trapping specifically in non-invasive ventilation?
Yeah, let me just load up my slide here. Okay, let me see if I can share it entire screen. All right, let's see, share. All righty, so let me. I don't know if you can see my cursor. Yes, so
And yes.
on the on the screen here, when you look at the flow graph, all right. So if you look at the expiratory graph, you want to make sure that at the end expiration it reaches the zero line. Okay, but if it doesn't, like in here, that's when you have auto peeping or air trapping, and this is the same as you're working with mechanical vents. So you just have to pay attention to the graph, and then you probably want to adjust your EPAP accordingly.
Wonderful. Thanks for the information. So, one question also that came in is, right, specific to, obviously these devices are used for a multitude of disease states. So in your experience, what are the disease state or the disease states that are most well treated by this type of therapy, right? We have, from the durable medical equipment side, we talk about how qualifications are everything from neuromuscular diseases, disorders of the diaphragm, respiratory, sleep. So, in your opinion, what are those disease states that are most well treated by this type of therapy?
I would say COPD. That's a big one. I would say people with any type of restrictive lung disease, for example, anybody with a neuromuscular disease like ALS, or a rib cage abnormality like scoliosis. Those are good ones. Patients with obesity hypoventilation syndrome. So those are the types of patients that would most benefit from this advanced type of NIV.
Yeah, I'm glad you brought up obesity hyperventilation syndrome. Definitely one that we've seen as a growing diagnosis for these types of therapies. One that's always been approvable, but hasn't been really identified for this type of therapy for the initial years of non-invasive ventilator being available in the market. So another question rolled in specific to your discussions around the Respironics products, and they wanted to know if all the info that you were sharing transfers over to the ResMed TX link, or if you have any insight on that.
So yeah, there is I guess the settings it can cross over. I have to find it in my computer because I have sort of like a translation table where you can transfer Respironics settings to AVAPS settings. Yeah, on the TX, for those who are referring to the sleep labs for their titration studies, yeah, the TX does have the IVAPS mode. So the only thing, I guess uh, the things that don't translate directly is the alveolar ventilation and target tidal volume. But I think the rest, in terms of EPAP and then min and max pressure support, I think backup rate. I mean, uh, that can translate. Now, the titration protocols are different from an AVAPS titration to an IVAPS titration. In my opinion, I mean, both. I looked at both protocols. They're kind of wonky to me. So I developed an IVAPS protocol for our own lab, and I think, in fact, ResMed has contacted us to share their protocol to the labs when they're doing their in service. Um, but I think if you just go over principles, in terms of treating the obstructive first, then you can treat the treat the hypoventilation by manipulating tidal volume or alveolar ventilation, and backup rate, and you should be okay.
Wonderful. Well, thanks for elaborating on that. Obviously, we have a lot of clinicians out there that are looking for some guidance on how to utilize and where to utilize these therapies. So we have time for just a quick question. I think it's the perfect question to squeeze in under the wire. I loved how you mentioned about ResMed coming to you for some of your resources, but the group out there watching has asked you specifically, where do you go to for some of the resources that you utilize to make these decisions? Do you have any guidance for them as to whether it's, CMS or payer related or clinician related, but where do you go to get some of your information on these items?
Well, I think for me, I'm fortunate to have a good relationship with the reps from both ResMed and Respironics. So they educate me. Well, when IVAPS first came out, our lab is mostly a ResMed lab. So so when it first came out, they introduced me to this mode, and I really got hands on. And
Mhm.
so I talked to the rep and their uh, uh, medical representative part, and they also educate me on the CMS, guidelines. I know somebody had a question like, how can I qualify a patient on IVAPS device? And then on the Respironics end, I just talked to the reps about when the V60 came out, and they sent me their manual and their titration protocol, and I just picked their brains, and that's how I became more familiar. And ultimately, it's just practice, really. Yeah, I mean,
Mhm.
you just got to do more with it. At least from a sleep lab standpoint, I would train I personally train our techs on how to titrate IVAPS in the sleep study, and then they'll give me feedback on what their experience was, and based on their feedback and based on the titration data, I would maybe make some tweaks on the protocol.
Wonderful. Well, thank you, Dr. Gillian. We're so grateful for your time and being willing to share your expertise on the matter. Thank you for joining us for the Q&A, and good luck with you and your care for all of your patients. Thanks so much for being part of this event today.
Thanks everybody.
Take care now.
You too. Thanks.